All right, so a little bit of GI. Well, based off of your notes here, you have a chart. I hate charts. Charts are memorization, and that's the one thing we're trying to get you away from here. But those of you that are pebble flippers here in the class, I thought I'd put a chart in there for you so you can memorize something. The first column is the one they're going to ask you about. That is the most important column of this whole sheet. If I'm talking about the foregut, the midgut, and the hindgut, what is the arterial supply of that area? Celiac, as you can see, for the foregut, superior mesenteric for the midgut, and inferior mesenteric for the hindgut. So if I have any problems with the blood supply of those areas, therefore I will have a deficit in the development of those areas. And we said the teratogenic period is during what weeks? 4 to 8 weeks. So any teratogen prior to 4 weeks, either she'll abort or she'll keep the fetus. Anything after 8 weeks, 8 to 9, right around that window, anything after that, I wouldn't expect any damage to any of the layers of the disc. Okay? All right. So the foregut gives rise to the GI tract from the mouth to the second part of the duodenum. What is that? Well, right where the biliary tract comes into the duodenum, that's about where the second and the first part divide. So right to that area, including the respiratory tract. Lungs and upper GI have many congenital connections. Why? Because they come from the same laminar disc. So if I was to draw this, shoot, all right. Esophagus comes down into the stomach, past the pylorus, first part of the duodenum, right into the second part, where the biliary tract. We have our third part, which is our duodenal bulb, and on down. Okay, so there's really technically 4 parts of the duodenum. And your fourth part runs right along your IVC. They love to ask about that. Or they'll give you a CT of the abdomen, and you'll see the IVC, and then a big circle right next to it. That's the fourth part of your duodenum. A lot of times they do anatomical identification for that. All right. So it gives rise to the duodenum to the from the GI, remember the mouth to the second part of the duodenum, including the respiratory tract, because they came from the same germinal layer. The midgut extends from the second part of the duodenum to the splenic flexure. Splenic flexure. Why is that important? Well, I know with the splenic flexure, that's an area that has the least blood supply. Why? Well, based off of just anatomical orientation, God bless you, you know what to do next, run. Based off anatomical, if I'm looking the ascending, the transverse, the descending, colon, and I have my superior mesenteric artery, I know that it supplies all these areas. And there are collaterals between them. If I affect one, ultimately, I can still get blood supplied to that area. Now, the inferior mesenteric, IMA, goes right up here. And you can see that ultimately there are collaterals that will connect between there. But where's the problem area? Right at the splenic flexure. Right at the splenic flexure, because there's no collaterals between that area. So if I have somebody iatrogenically infarcts that area, maybe there's a dye that I'm giving them for films, and ultimately they're talking about left upper quadrant pain. Maybe it's a neonate whose vessels haven't totally formed yet, who has problems with GI bleeding and things like that, infarcts an area, watershed area. Okay? There's no collaterals in that area. What if I have an elderly patient who has atherosclerosis? What area do you think would be affected first? Left upper quadrant, watershed area. So these are the areas associated with the least blood supply. So if I do anything to decrease that blood supply, so let's say, talking about atherosclerosis, if I have a person, when you eat food, we'll go there. When you eat food, you should know that blood gets shunted to your stomach to help process that food. So if my left upper quadrant is has the least blood supply and even has less due to atherosclerosis, you can understand why an elderly person would come in with left upper quadrant pain every time they eat a meal. This is why. All right. Develops in yolk sac, must go through a 270-degree rotation, migrates from the yolk sac into the abdominal cavity. What does that mean? Well, the midgut is the only part that goes out into the abdominal cavity, or the yolk sac, I should say, rotates 270 degrees and comes back in. How does it rotate? It uses dining arms, or cilia, to crawl along that wall to go ahead and do that rotation. If there's something wrong with the dining arm, or the cilia, the mitochondria of the cilia, doesn't matter what the situation is, it's not going to rotate 270 degrees. That's why we have patients with what we call dextrocardia, right? The organs are on the opposite side of the body. This is why. This is where it happens. So if they give you films and there's a heart on the right side of the body, first of all, make sure that you're looking at the right side of the films. They always have an R and L at the bottom. But if they are, then always go after dextrocardia or inversion. All right, so midgut rotation, and we call that Kurtagner's sinus inversus, right? Ciliary problem. And for the hindgut, from that splenic flexure all the way down to the anus, remember we have the watershed areas, that splenic flexure. Has the least blood supply, most susceptible to ischemic infarcts, and we talked about that. Okay? So any form of atherosclerosis, any prematurity, things like that. Remember, when that's one of the risks of preterm infancy, is that your blood vessels aren't totally formed properly. They have actually increased pressure, ICP. Why? Because they're bleeding into the ventricles, the blood vessels along the ventricle walls. So they're not making more CSF, it's just blood adding to the CSF. Very common in preterm infants. Right? All right, so how are we going to look at the GI system today? We're going to start from the brain and work our way all the way down to the anal sphincter. From the mouth all the way down. All right, so neurological sensory information. Sensory information, key word being sensory. So when you think about food, hear food, smell food, taste food, it's all sensory, folks, all sensory. What do you think is the strongest stimulus to food? Smell? Sight. It's sight. Let me explain why. Think about this. You're in that restaurant, and you're full to the gills, you can't eat anymore, you're stuffed. Waitress comes by and says, "Oh, did you save room for dessert?" You're like, "No, no thanks." And she walks away. She hands you the check and says, "Take your time." Why did she say take your time? Because she knows your eyes are going to deviate over to that little color pitcher sitting there on the end of the table with that shiny icing on top of that chocolate cake, that ice cream, that cobbler that looks so good. "Oh, but I'm so full. But I'll take one, please." And then you order that. She's happy because you run up the bill even higher. But the key here is that sight always, always, always is the strongest stimulus to food. Have you ever been to a restaurant where you open the diagrams and there's pictures? You think the pictures are there because people can't read? No. Well, maybe, but no. The key is that why? You'll go, that one looks really good, and I'll order it. And then when it comes to you, you're like, what the hell is this? It doesn't look anything like the photograph, does it? Yeah, get this junk out of here. Yeah, absolutely. So sight. All sensory information must reach the cortex. All sensory information must reach the cortex via the cortical bulbar pathway. No longer do we do a vagotomy for peptic ulcers that can't enjoy food, because we do what's now called a highly selective parietal cell vagotomy. The problem is, as I told you the other day, if I cut that vagus nerve, they're going to lose all that sensory information. They're going to think about food. They're not going to smell food the way that get that deriving pleasure. And these people would starve themselves to death. And we used to cut the vagus nerve, as I told you, because we used to think that cutting the vagus nerve would decrease the acid, which it does, because that was the problem with ulcers. And that's not the problem. It's loss of barrier. Loss of barrier, not the amount of acid. The only time it counts with the amount of acid is in what type of pathology? Where I get ulcers all the way down to my distal ileum? Zollinger-Ellison syndrome, correct. That's when I know acid is causing those ulcers in the distal ileum. It's not loss of barrier. All right. So the cortex can override any basic urge. The cortex can override any basic urge. So the outer layer of the cerebrum is derived from the foregut. So what does that mean? Well, the limbic system is responsible for all basic urges. All basic urges. So we have the hippocampus for long-term memory, and the amygdala is your reward and fear. So with the hippocampus, talk about that for a second. That's basically, remember, you have it bilaterally, right? And it's on the medial aspect of your temporal lobes. The medial aspect of your temporal lobes. And that's responsible for long-term memory. Long-term memory. So let's make it more clinical. If I have a patient who has Alzheimer's disease, this is one of the first areas to go. Your hippocampus is one of the first areas to go in Alzheimer's disease. Now, I said it's for long-term memory, but it's also for something called spatial navigation. Spatial navigation. So think about it, an Alzheimer's patient. They obviously have problems with long-term memory, don't they? Creating new memory, we call that anterograde amnesia. They have a problem with retrograde amnesia too. Not the fact that they're losing it, they have a problem retrieving it because of the tau proteins. They have a problem retrieving it. So they actually have anterograde and retrograde amnesia, but remember the retrograde is due that they cannot retrieve that information. Spatial navigation problem is where, don't they look confused? They're on the wards or lockdown units and they're walking around very confused. The amygdala is storage for memory that has emotion to it. Oh, ho, ho, he broke up with me. Well, who's going to be responsible? The amygdala, because you're going to remember that guy and you're going to hate his guts. Oh, I saw her with another guy. Emotion, you're going to remember that. The amygdala, right? The amygdala is responsible for those type of things. So, again, hippocampus and limbic system. Woo, circadian rhythms. Circadian rhythms. From the pineal gland, which you guys know, melatonin is that main neurotransmitter. It's sometimes called the hormone of the dark, or hormone of the night, is a term that a lot of scientists use. Why? Because I know that it's high at night. It's elevated at night. Melatonin does what to you? Makes you what? Lethargic, tired, sleepy, things like that. How do I know you throw off your circadian rhythm? You go up to Chicago. It's middle of the day. You fly to Australia. By the time you get there, it's daytime. Your body's screwed up, isn't it? Because basically you're going from a light scene to another light scene. You throw off your circadian rhythm. What do we call that? Jet lag. Right, jet lag. And the thing about jet lag is that it takes about 2 to 3 days for your circadian rhythm to reset itself. That's why you kind of feel like crap for 2 days, 3 days. You get off that plane. You're all excited. You get to that motel room. You start bouncing up and down on that bed because you're so excited that you're there. And then you're ready to hit the beach and have a good time. But what do you want to do? All you want to do is sleep in that motel room. Or those of you that run out to the beach and fall asleep, you wake up with one hell of a burn. But, you know, hey, thanks to the circadian rhythm throwing off melatonin. Now, you know, we can take over-the-counter melatonin, correct? You guys familiar with that? That you can do that? This is the same. This is what's unique about that. Since it's exogenous, it does not change your endogenous melatonin. Does not change your endogenous melatonin, only because you're taking it exogenous. You're adding to whatever you have. So if that's thrown off, you can see how you can actually make it worse. That's a danger to it. You have a question? No? All right. All right. So, morning, catabolic processes are highest function. Working out in the morning is the best. Anybody take vitamins here in the morning? Good, good, absolutely. Doesn't matter what age you are, you should, because you don't eat right. I don't care how well of a diet you think you do have, it's not well balanced. Because you know that 5-star restaurant you go to, right? McDonald's. So, when should you take vitamins? At night? In the morning? In the morning. When? With food too? Maybe, maybe not. We'll talk about that. Fat soluble. Do I need food to absorb those?
But I heard that they're absorbed.
You heard. Uh-oh. Go ahead.
Because it's absorbing the fat from the food.
Okay.
The absorption of the vitamins.
Let me ask you this. Let's say somebody has a problem where they can't get bile out. Are they going to be able to emulsify that fat from their diet? No. Are the fat-soluble vitamins going to hang in with that fat too in the stool? Yeah, and they'll pass it right out. But if I turn around and take fat-soluble vitamins independently of where I need bile to emulsify fat, I can absorb them, right? So that's knowing your physio. Yeah, you know your physio, then you go, They don't know what they're talking about. So absolutely. So again, what's a drug that we want to take at 8 o'clock at night? That not us, but we recommend it. Statins, right. That's the one where HMG-CoA reductase is the busiest at 8 o'clock at night. But every other drug, when should you be taking it again? In the morning. You should work out in the morning. Your catabolic processes are their highest. You know, I don't know if you guys know this, but the best way to lose weight outside of what I told you, eating small meals throughout the day, is also to eat prior to exercising. Did you know that? Yeah. Think about this. If I'm on a treadmill and I'm doing my exercises and all that, doesn't my body need glucose to increase the metabolism of those cells? If you go to the gym on an empty stomach, do you have that glucose floating around for that metabolism? No. Your cells will not burn. You think you are, but you're losing water weight. You're not burning fat. That's the difference. So again, you have to, basically, if you eat, you're feeding your metabolic process to help burn those cells down and burn up the fat. Not just lose water, because why? You're sucking down water when you're on the treadmill anyway, right? Putting it right back. All right, so with the pineal gland, melatonin comes from tryptophan. And we said melatonin does what to you again? It makes you lethargic, kind of sleepy, things like that. Well, from tryptophan, from milk and turkey, is this why elderly like to drink warm milk before they go to bed? Oh, or not elderly. Okay, that's why you guys like to drink milk before you go to bed? All right, okay, let me rephrase myself there. How about when you go to grandma's for Thanksgiving with that turkey? Yeah, you suck down that turkey, and all of a sudden you find yourself face down with your ass in the air on the couch because you're exhausted. Tryptophan. Yeah, tryptophan from the turkey. What's the one thing you should not be eating before you take your Usmle test and drinking? Milk and turkey. Don't eat a turkey sandwich for lunch. You're crazy. Don't do it, and don't wash it down with milk. All right, bright lights and companies. Bright lights and companies. Those of you who have ever been, maybe have, or toured a factory, you know it's very bright inside those factories. Why? Keep them awake, right? Yeah, there's this Hawthorne thing where if I watch this person, they'll work harder. Oh, heck with that. I'll just turn up the lights. I know that I will affect their melatonin levels. Now think about this for a second. If it's a third shift worker, they're going to be in a factory where it's very bright outside. Well, they do get a lunch break. Where do you think they go outside if they're smokers? They go outside into the back picnic area, and they start sucking their cigarettes down outside of the cancer stick in their mouth. It's pretty dark outside. What's going to happen to their melatonin levels? Increase. So now this individual may be outside for half an hour on their break or whatever, goes back in and sits down on that assembly line. Now you understand why we call him Two Fingers Tony, Knuckles Tommy, right? Because they're losing extremities working on these equipments because their melatonin levels were bouncing. That's how workers' comp came about. Because why? A lot of companies would turn around and say, well, we have a 5-finger limit, and ultimately this guy lost a couple, got to let him go. And a lot of individuals were getting hurt on the job because of melatonin levels. Do you know that car insurance, if you work third shift, is much more expensive? Right, think about it. So you get off in the morning, and all of a sudden, especially if it's 6 o'clock, maybe in the winter, it's dark. You just come out of a light factory. Guess what? You're going to wrap your car around a tree, or you have a higher probability of doing that. Why else is life expectancy decreased in third shift workers? They get off, if they make it home safely from driving. They walk in the house, if their loved one's making them breakfast, eggs, sausage, whatever. Ooh, that smells good. You sit down, and she fixes you the dinner, or breakfast. You eat all that breakfast, and then what do you do next? You go to sleep. You know you only burn 500 calories when you sleep. You think that's a hell of a lot more than 500 calories, sucking down the eggs, the bacon, all those hash browns? Absolutely. So you add to the comorbid conditions the longer you're on third shift. Reality. Anybody been in a casino here? Liars. So, yeah, absolutely. Outside of walking the casino and getting past all the kids that the parents leave at the front door, when you walk in, have you ever seen windows in the casinos? But you see bright lights. You see the alarms going off. You're all excited. Woo! I'm here to gain some money. And then you walk out going, crap, I lost some money. Right? But you tell your friends, hey, I'll meet you in 2 hours. 8 hours goes by, $500 later, you're like, damn. Yeah, because why? You're so wrapped up, the lights are going, so those mafia bosses know their physio, don't they? Yeah, they know what they're doing. So, all right, first, second, and third shift workers, workers' comp. Well, I remember when I was first on the wards of the hospital, I wasn't real strong on my physio. I wasn't married to my wife at the time. I was single. And I remember phenotypically the nurses walking by. I was like, oh, I'm going to like this. Yeah, this is nice. And then as the day progressed, because I was on call, then second shift came around. I was like, ooh, not as good phenotypically. Third shift rolled around. Oh, my God, hirsutism, everything. Oh, no way, what's going on? I said, this is wrong. Why would they put all these individuals that are not phenotypically appealing? Why do they put them on the third shift? Oh, I know, because they don't have visiting hours, and we want to keep, the hospital having a certain demographic approach and, a look. I didn't know my physio. So obviously what happened? Think about this. The lights in the hospital ward in the evening, aren't they a little dim? But these individuals are still eating, aren't they? They're still going through the night. Yeah, so their melatonin levels, what's going to happen to their catabolic processes? Decreased, but they're still sucking those calories down, right? So unfortunately, you succumb to the third shift of the hospital. But I didn't think that was the reason, so. Yep, they put the ugly ones on the night shift. All right. Yeah, I didn't know my physio. All right, let's see anything else here. Cocaine, LSD. They both increase melatonin levels. Think about that with LSD. Aren't they lazy, slow? Same with cocaine. It's up. Melatonin levels are high. But think about this. If melatonin levels are low, that's one of the things that they feel is associated with autism. Isn't that kid always hyperactive? Doesn't want to be bothered, doesn't want to talk to you, really good at one thing, unique, likes to be held not necessarily by the caregiver, but somebody. Yeah, so they think that melatonin is associated with that. Lots of research on melatonin. Lots of research going on. All right, so the hypothalamus. What do you need to know in the hypothalamus? Well, we have the feeding center, or the hunger center, located in the lateral hypothalamus. Stimulus, feeding. So anytime your glucose falls, this is a stimulus for hunger. So remember I told you, if you're doing a starvation diet, you're going to stimulate your hunger center. You can make it day 1, day 2, day 3, no way, you're done. That's where you find yourself back in the buffet line. Again, you must eat small meals throughout the day to keep this center shut down. If sugar remains normal, the center will not fire. If I have a situation where I destroy this center, there's anorexia nervosa, folks. That's anorexia nervosa. Now, if I tell you that a patient comes in who's turning around, has thin body weight, purging, lost enamel on their teeth, on the back of their teeth, cuts on their fingers, what do you think the diagnosis is? There you go. I was waiting to hear that. You guys jumped right on bulimia based off of purging. Don't do that. That's wrong. You have to ask me what the weight is of the individual, because they both purge. They both purge. Also, for anorexia, I know these individuals also do excessive exercise. Okay, so if it's anorexia, I know it's a BMI less than 17, right? They're thin. They're very thin. Very thin. Versus bulimia, I know that they're more obese. Chunky is the term we use for that. We'll be politically correct. We'll come back to the other side. We'll talk about it. So anorexia nervosa, starvation, desensitize your hunger center, body dysmorphism. With body dysmorphism, be careful with that, folks. That's usually where they don't like a certain appendage of their body. They don't like their nose. They don't like their mouth. They don't like something like that. And they're constantly diving over to Dr. 90210 to get plastic surgery, right? All the time. Look at Michael Jackson, right? It's like his nose just ended up back where it was. Small body frame thinks they're overweight. So think about it. If you've ever been to a carnival, you know they have those funny mirrors that you can kind of stand in front of, and all of a sudden you look like you have achondroplasia or something, you're a little short with big arms and things like that. That's what these individuals when they look in a normal mirror, that's what they see. Not what you see, but this is what they see. It's a young female trying to please her mother. So this is a mother who is somebody successful, like a lawyer. Nah, not a lawyer. A physician, right? Lawyers aren't successful, right? Come on. Do you respect lawyers or do you fear lawyers? Do you respect doctors? You respect doctors, right? You're all doctors, right? You respect doctors. Lawyers, not successful. All right, so it's somebody who's trying to please her mother, but can never do it. No matter what she does, never pleases her. BMI less than 17. Versus jump over to bulimia. Thinks or enjoys eating, chunky female, tries to please her boyfriend. This is somebody who loves to eat, but then feels guilty about it afterwards. Loves to eat, but feels guilty about it afterwards. Purging, the abrasion on the knuckles, tooth enamel erosion. Laxative abuse. We had this one patient who came in, and she was taking 15 packs of laxatives a day. A day. You think her porthole was sore? Oh, yeah. She was blowing out of it all day. Laxatives. Crazy. Couldn't talk her off of it, just had to bring the number down a little bit. And BMI greater than 25. Now, going back to the Satiety Center, location, ventromedial nucleus of the hypothalamus. So remember, medial being the center section, larger there. Stimulus is stop feeding, so increase glucose. And stomach stretch will stimulate the Satiety Center. Now remember, I talked to you about the Billroth procedure, or somebody undergoing bariatric surgery, and that's the hypothesis here. If I make that stomach smaller, the stretch will stimulate the Satiety Center. But you can override that, can't you? With what part of the brain again? The cortex. This is why having bariatric surgery doesn't necessarily work all the time, right? Because you can override it. Now, destruction of this area is also called hypothalamic obesity syndrome, or otherwise known as Prader-Willi. Prader-Willi. Let me tell you a little about Prader-Willi. Prader-Willi is one of those individuals you don't want to go out to eat with. You will not enjoy your meal. If you're sitting in the park having your lunch and you have a hamburger in your hand and Prader-Willi walks by, you will lose that hamburger. Prader-Willi will take that hamburger out of your hand. There was a show on PBS one time I was watching on Prader-Willi syndrome, and these parents had to actually put a big chain all the way around a refrigerator because their child diagnosed with Prader-Willi was ripping at their refrigerator to get to that food. Think of somebody on PCP. Aren't they really aggressive, super strength? Now mix that with Prader-Willi. That's like your worst nightmare, right? So it's somebody really, really aggressive that wants food. Will do anything they can to get food. If you're in the hospital wards and there's a Prader-Willi patient on that ward, sit back and watch when nutrition comes by. You know how nutrition has that cart with all the food in it, and obviously they have that crooked wheel, so you always hear them going down the hallway. Ooh, that's all Prader-Willi's listening for. Ooh, here's that cartwheel. All right. And he kind of sticks out his head out, but obviously he's so big, so 3/4 of his body is sticking out of the room, and he's looking all the way out, and all of a sudden he hears that cart, and that nutritionist takes that food into the room. Woo! Prader-Willi's got lunch. Comes running down or rolling down that hallway and grabs that cart and takes off. I'm telling you, Prader-Willi. Huge, huge appetite. What do they die from? What do you think they die from? Overeating. All right, which ultimately leads to heart failure, right? That's a comorbid condition, right? Overeating. Overeating. So lesion in the Satiety Center, uniparental disotomy. Let's see, one parent carrying the lesion, parental in origin, P for P. Prader for paternal. It's one of your nucleotide repeats on chromosome 15. Very, very aggressive appetite. Very aggressive appetite. They will take your food away. All right, so body weight. Let's talk about that. This is what we call ideal body weight. Folks, this is a plug and chug for the boards. God bless you, run. This is a plug and chug for the boards. That's all it is. So what's ideal body weight? In men, 5 feet height, we start at 106 pounds. Women, 5 feet, we start at 100 pounds. We add 5 pounds for each inch beyond that. If they have a small frame, not very muscular, very thin, frail, we add 15 pounds. If they're a large frame, very muscular, we're going to add 30 pounds. So I gave you an example. A male, 5'10", 106 pounds you start with. You add 5 pounds for each past that, which is the 50, and we'll say most are large frame, that's 30. So ideal body weight for a male 5'10" is 186 pounds. 3/4 of Americans aren't anywhere close to that weight, right? But that's ideal body weight. So what's considered obesity in America, BMI-wise? Greater than 25. 25, don't mix it up. Greater than 25 BMI, you're considered obese. What is the number or magical number for, let's see, morbidly obese? 35. 35, morbidly obese. 35. 25 and 35. So this is a plug and chug if you get this on the boards. Yes?
You mentioned about melatonin and cocaine. If they lack.
No. If you, LSD or cocaine both increase melatonin levels. So they're notorious for making you drowsy.
Cocaine makes you drowsy.
Oh, yeah. Initially, you get that buzz, right? That amphetamine hit, and then you're going to start hitting a low. It takes usually about 60 minutes, about an hour, a little over an hour. All of a sudden, just because the melatonin levels are that high, all of a sudden you hit a drowsy phase. Same with LSD. Same exact thing. Yes. You wouldn't think it, you think it the other way around, but it's not. Overweight? Yeah, you're overweight if you have a BMI greater than 25. You're morbidly obese if it's greater than 35 BMI.
So the next step for obese then is greater than 30.
No. Obese is greater than 25 in the United States according to our growth charts. If you're morbidly obese, it's greater than 35 BMI. And that's what insurance companies claim it at too. Obese and overweight? Well, it's semantics right there. That's really all it is, because they both really say the same thing, don't they? Right, for the boards. Now we're approaching it from the board's point of view or how they're interpreting it. But remember this way. If I turn around and I have a BMI of 20, you got a little extra meat on you. Doesn't mean you're obese characterized by the medical community. You're obese once you break a BMI of 25. And in that's the classification. So if you have a patient come in and has a BMI of 26, you want to put them on a weight reduction program. If you have a patient comes in with a BMI of 21, I don't have to necessarily put them on a weight reduction program, but I say, you know, be careful, you're kind of getting to the outer limits here. And that's really what that is. All right. Yes? Yes? No. I was just saying, I was using an example of PCP, how we always think somebody's very aggressive, very strong. Prader-Willi, I was just making an analogy, is just like that without PCP. They're just really aggressive, but for food. PCP, they just want to fight everybody in the world. All right? I'm sorry? Absolutely, because they're using or consuming more calories than they're actually possibly able to burn. Even though they're putting a lot of energy into getting food, it's never equal. All right, so neurotransmitters, norepinephrine and serotonin, more important. So many people use, serotonin is more important, so many people use amphetamines for weight loss. Weight loss. Now, wait a second. 80% of the time it stimulates the satiety center. 20% of the time it stimulates the hunger center. You mean, so if you run to that pharmaceutical store, let's say Walgreens, whatever, and you grab some Dexatrim to lose weight, you could gain weight 20% of the time. If you read the small print on the bottom, it says it may cause weight gain. And all these people or individuals are sucking that down trying to lose weight. And they actually end up gaining weight. Okay? Can stimulate weight gain. All right, so with the amphetamines, they're taken up presynaptically, causing release of catecholamines. Taken up presynaptically, causing release of catecholamines. So increased dopamine, norepinephrine, and serotonin. Nausea and vomiting, because it stimulates via dopamine. Dopamine stimulates the central trigger zone of on the floor of the fourth ventricle. That's responsible for nausea and vomiting. So dopamine, if you turn around and I give somebody a dopamine agonist, you already know a side effect, nausea and vomiting. That's what it is. If I talk about neuromuscular, basal ganglia, they get the tics. So you mean somebody like who has Huntington's disease has gross motor movement problems? Right, it's due to dopamine, too much dopamine. Amphetamine toxicity on the boards, I want you to always, 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 folks, on the boards, if you ever see a vignette that says vertical nystagmus, you're done. Drop down, pick an amphetamine on the list. There's only one on the list. It's pathognomonic for amphetamines. Vertical nystagmus, amphetamines. If they turn around and they tell you that that person is aggressive, beating everybody up in a local bar, and on physical exam you see vertical nystagmus, the drug is PCP. That's what I want you to do. I want you to always pick an amphetamine associated with vertical nystagmus. If I look at some of the amphetamines, we talked about methylphenidate, Ritalin, right? Most overly prescribed diagnosis in the DSM-4 criteria, which is hyperactive attention deficit disorder. And what did I tell you most of those kids need? Swift kick in the ass, right? That's what it is. Most of them need that. But we're too afraid of who not to do it? Those unsuccessful people, right? Lawyers, right? Yeah, absolutely. Yeah, but that's really what it is. Kids need a little bit of corporal punishment, and ultimately they don't need these problems. Now, so methylphenidate utilized for Ritalin, narcolepsy, hallucinations as you fall asleep. So again, all amphetamines can cause hallucinations as you fall asleep because serotonin is notorious for that. Pimelin, the reason we have that on here is off the market for hepatic necrosis. It's still on the boards, and they'll ask you why it's off the market, and basically it caused drug-induced hepatitis. Dexedrine, dexedrine, again, being an amphetamine itself, dexatrim would be over-the-counter for weight loss. Over-the-counter for weight loss. So with dexedrine, remember that ultimately we take that drug, dexedrine, and we mix it with racemic amphetamines, and that's Adderall. That's Adderall, right? And I know I've had a number of students come up to me and tell me that they're taking Adderall. And this is what you're really taking. It's a dextroamphetamine. So again, it's just a stimulant. Dexatrim is, again, for weight loss over the counter. LSD, hallucinations from serotonin. Remember, how do I know somebody was on LSD? Well, in the late 60s, early 70s, all those songs came out. I know that they have hallucinations, and how do I know that with LSD? Because they see vivid colors and patterns. How do you know that? Just turn around and listen to the songs. Have you ever seen a yellow submarine? You ever see a purple dragon? Right? They tell you all the old songs from the 60s and 70s. I know that basically a lot of LSD was floating around at that time. Well, if I look at PCP, I told you somebody who's very violent. Long before I became a physician, I was a firefighter paramedic for a city, and we got a call one day that we always rolled an engine and a medic together just for manpower. And it was a call where there was this guy who they thought was having a hypoglycemic effect. And remember, hypoglycemia can present like PCP. Okay? Hypoglycemia can present like PCP. Altered level of consciousness, real aggressiveness. It'll look like a PCP patient. Well, we arrived on scene, and there was about 8 of us that walked in, everyone over 200 pounds. And we came in with all our gear. We walked around the corner, and at the end of the aisle was this little guy. He looked like a leprechaun to me. Or you guys, there's that show, funny show on TV where that midget does all the stupid stuff. But this guy was a little dude, and we thought, oh, that's no problem. But it was funny because when he saw us come down the hall, or down the aisle, he got in a stance like this. And we're like, and we started chuckling. Oh, what's this little horse jockey going to do? So we get down to the end, and I, just by Murphy's Law, happened to be the first one down there. And all I remember is that as I got closer, he just took me and went like this, and I ended up in the milk. So I had milk all over me. Oh, I was so mad. He took every one of us out. Everyone. Thank goodness the cops came in. tasered him. But it was kind of cool. I was a little worried because I'm laying in the milk and I got this electrical activity going around by me because the cop's like, oh, we got him. And this is the unique thing about it, why we knew it was PCP, because after they tased him, he just went and he pulled these tasers out of him and kept walking towards the cops. Well, needless to say, any cop who sees that is going to draw his gun. Somebody in PCP doesn't matter. They don't care. If you ever watch the show Cops and you see anybody pulling the tasers out of their chest, they're on PCP. Unbelievable strength, just massive psychosis at that moment. Oh, and eventually he got boarded down, and what you do is you tape these people down or strap them down to a baseboard face down, because then they can't hurt anybody. I think an episode of ER had something like that, right? It was a patient walking out of the hospital with a gurney, which is about 400 pounds, to his back, just walking out. He wanted to leave. I mean, it's just unbelievable strength, mind over matter. So PCP, really aggressive. Ecstasy, awesome drug. No, I didn't take it. Let me clarify that. I did not take it. Have you guys heard of ecstasy parties? You ever heard that? Yeah. This is where your drug lords learned their physio. They learned their physio. Let me explain. So there was this, what they do is they have a factory, an empty factory, and they bring a DJ in there and they set up a bar and they have the ball going and the music and everything's pumping, and they bring all these kids in and they have ecstasy all over the tables. Well, all the kids come in, they're having a good time, they're dancing, they're popping the ecstasy and things like that. And then what's so unique about this drug is it drives your thirst through the roof. Makes you very, very thirsty. So what happened is a lot of the kids would go up to the bar and say, hey, man, I don't want to drink, let me have a glass of water. Bartender says, no problem, puts a bottle of water on the bar and says, that'll be $300. Most of those kids don't have $300 for them. Reason I think this drug's so unique is because we actually had a case of this, and we arrived on scene the next day, and what actually we found when we went into the factory was that there were a bunch of dead kids in the bathroom because they were fighting each other to drink out of the toilet bowl. Obviously they died. Why? Because if I have this drive for thirst, also my body temperature goes through the roof, and it basically denatured the proteins and they had a heart attack. That's what happened. It's an amazing drug. So if they ever give you on the boards, anybody who has a situation where they're turning around and they have this incredible drive for thirst, and it's a teenager usually on the boards, I want you to pick ecstasy, okay? Ecstasy. Hypothalamus controls menses. Progesterone stimulates the hunger system. And in pregnancy, it's usually due to the corpus luteum, so progesterone. So think about this for a second. If progesterone is responsible for hunger, is that why as you get closer to your menses, all of a sudden you start digging out that chocolate? You start looking for those potato chips? You start digging all over the place. Pregnancy. I'm learning this the hard way with my wife right now. 2 o'clock in the morning. Could you get me something to eat? Ah, shit. I teach tomorrow. But I'm hungry. If you love me. So, yeah, there I'm out, sweatpants, ball cap, trying to go get something to eat for her. So, but yeah, pregnancy drives, due to progesterone, drives hunger. So again, it's not your fault. All right. So, controls temperature. Controls temperature. Why is that important? The anterior hypothalamus cools, inhibits norepinephrine. So a lesion of the anterior, they die of hyperthermia. So remember, the anterior hypothalamus is responsible for cooling, versus the posterior hypothalamus warms. Therefore, a lesion of the posterior, you die of hypothermia. So how could they go after this clinically? Well, acetaminophen, you all should know, is used for fever. So stimulates the anterior. Why? Because it's trying to cool the body and it blocks the posterior, where it's preventing the body from increasing its temperature. Is that a good thing? Is that a good thing to knock out fever? No, it's a bad thing. Let me explain why. Why is your body's temperature going up in the first place? Why does if you get an organism in your body that shouldn't be there, why is your body temperature increasing? To kill the organism, to denature its protein. And then all of a sudden you're going to pop an acetaminophen to stop your normal body metabolism from fighting that organism? You feel better because you're cooler at the moment, but who loves it? That organism, because they can hang around longer. It's not a smart thing to do a lot of times. Obviously, if you go over or close to 104, you better be taking that acetaminophen because you don't want to induce seizures, especially in children, right? Now, toxicity causes microsteatosis. Microsteatosis. But wait a second. Right behind that, I have Rye syndrome in children, but I thought that was with aspirin. Isn't that with aspirin? Yes. But the reason I have that on there next to it is because it also causes microsteatosis. So on the boards, they could give you a case where somebody has acetaminophen toxicity and ask you a correlation question of another drug that would present exactly the same way. It would be Rye syndrome with microsteatosis. What does alcohol do to the liver? Macrosteatosis. So large fat globules. Is that reversible? Is that reversible? Yes or no? So if you go out and binge drink and all of a sudden get an enlarged liver that night, is that stay large? I hope not, unless you're still doing continuous keg stands throughout the week, and you'll keep it enlarged. But wait a second, that brings up a good point. Why is it that if you go out drinking one night, you get your boards, you're all excited, you got your 240, woo, I'm feeling good, I'm going to go out and celebrate, and you go out to the local bars and you start pounding that beer, and in the middle of the night you wake up with massive, massive right shoulder pain. Why? Al? Gallbladder? Arrows? Pancreas, gallbladder? Frank? Why? Anybody? Was it that the beer was too heavy? You're lifting it? That's why you got your short, sore elbow? Liver pushing on the diaphragm. Is there a nerve associated with that? Phrenic nerve. Doesn't that go up to C3, 4, 5, keep the diaphragm alive? Right, so think about this. You're out, you're pounding your beers, you're having a good time, you wake up in the middle of the night or next morning with massive right shoulder pain. It's not because it was too heavy. It's not because that lawyer punched you in the shoulder because you made fun of his ugly girlfriend. It's not because of any of that. It's because ultimately you cause macrosteatosis, stretching that liver capsule, pushing up on the phrenic nerve, ultimately radiating or what we call referred pain to the shoulder, and that's how you have shoulder pain. So let me ask you this. If somebody has gallbladder surgery, isn't one of the side effects right shoulder pain? Won't you be manipulating that liver and irritating it? If I take a liver biopsy, won't I irritate that shoulder? Absolutely. If somebody has a splenic problem, won't they have left shoulder pain? Anything that pushes up on that diaphragm. You mean to tell me somebody has an ulcer and perforates, they'll have air under the diaphragm, lifting up on the diaphragm? Won't that present with shoulder pain? Yeah, that's how they have it. It's the cool part about physio. Not off the top of my head. No. All right, so toxicity, microsteatosis, Rye syndrome in children. Treatment, N-acetylcysteine is a reducing agent. Those of you for step 2 and step 3, we have a chart that we follow, and it starts at the 4-hour level, and that's the one that we measure. So really, we don't worry about anything prior to the 4-hour level on the board. So the only thing they'll ask you is when do you intervene, and it's based off of the 4-hour level. And that would be your answer. They won't ask you any more than that. Okay? That'll be the depth of it. All right. Stress response. Woo, stress response. Parasympathetics are always first. Always first. Parasympathetics are always first. Remember that. You can go out and show me a whole bunch of books that tell me that sympathetic is first. They're wrong. They are wrong. When you leave this course, you'll realize how many textbooks are wrong. Why aren't so many textbooks wrong to begin with? How do most individuals write a textbook? They read other text. They grab a whole bunch of them, and they take little pieces from each, so it's not plagiarism, and then they put it together. And then a new version comes out. And then somebody grabs that book, and they're following the idiot in front of them who said whatever they did in their book, and that's why there are so many books out there where the information is just flat out wrong. Wrong! But you read it as the Bible, right? Because it has Harrison's written on the side of it, has a CMDT written on the side, so it must be correct. folks, if you know your physio, you can explain or rationalize why. This is why a lot of hospital protocols are wrong, too. And if you can prove right, then you can actually get protocols changed. Now, based off of this, parasympathetics are always first. How do I know? Well, heart rate is decreased, increased gastric motility, increased acid production. Well, if I increase gastric motility, then therefore I'll be blowing out my porthole, correct? Is that why just prior to a test, the line at the bathroom is all the way down the hall? Is that why when you are getting ready to go on a date, all of a sudden you run into the bathroom? Wasn't there the show Dumb and Dumber? He had a hot date with that girl in Aspen, and he had to run to the bathroom, and the bathroom toilet didn't work. Remember that? Yeah, those of you that saw it. Yeah, why? Parasympathetics are always first. Always, always, always. Followed by sympathetics. Now, how do I know this? Or what's the problem here? Well, at the bottom of the screen there, you see Hollywood and sphincter control. Long time ago, when movies came out, they just scared you, right? Freddy came out from the tree and took his hand and took out whoever he wanted. Sure. So you're on a date. You're all excited about it. Finally, she said yes. Right, Al? She said yes. And it's been a while. Okay, all right, personal thing. Let's leave those at home, but all right. So sometimes it's good to just retain, so don't share. So, all right. So finally she said yes, and you're all excited, and you told her that you're going to make her dinner, right? And she comes over, and you have a nice candlelight dinner and all that. This is your first date, and she's scared as hell because you're making it romantic. But anyway, so she comes over, and then she told you that she likes scary movies, but she likes old scary movies. You're like, all right, so you run to Blockbuster and get those scary movies, and you're all excited, and you pop them in the machine just prior to dinner while it's cooking and all that, and you figure you're sitting there on your leather couch with her, and she's going to get scared and slide over a little closer to you, right? You're going to use the movie to your advantage? Yeah, sure. But the problem is that ultimately in the older movies, you don't hear the right? You hear that during a movie, and you're like, ooh, something good's coming up, right? But in the old movies, they just jump out. Woo! Freddy would jump out, right? Who's first? Parasympathetics. What happens to GI motility? She shits herself, or you shit yourself? All right, so both of you decide to anoint the couch. Yeah, there you go. So both. You think the date's going to continue? No, it's over at that point, right? So now, so nowadays in Hollywood, now they have that noise, right? That why? Because it's allowing you to get past that parasympathetic phase. So what? All of a sudden you hear that loud snap, and that's your sphincter tightening up because you hit the sympathetic phase. You've got a permanent crease in your leather couch, but hey, it's okay. The date will continue at this point, right? So parasympathetics are always, always first, not sympathetics, okay? Parasympathetics are always first. All right, so stress ulcers, let's see, sympathetics, blood pressure, constipation, Al, which will help, right? Pulls blood from the GI, so you cannot buffer the acid. So stress from burns, we call those Curling's ulcers. And what actually happens there is, remember what did I say is the purpose of or the cause of an ulcer? Too much acid or loss of barrier? Loss of barrier. So if I'm going to lose my barrier, do this. So if I have my mucosal lining here, let's see, we'll put some microvilli on here because we're increasing that surface area. On top of there, I have something called my glycocalyx. Glycocalyx is from prostaglandins. Glycocalyx is a barrier. Outside of the glycocalyx, I also have a mucinous layer, which from the mucus cells, and then obviously my glycocalyx on top of that. So, is there drugs that decrease prostaglandins? Sure. Notorious what? Aspirin, NSAIDs, right? Just say NSAIDs. NSAIDs take out prostaglandins. If I take out prostaglandins, then ultimately I'll lose that glycocalyx, right? If I lose that glycocalyx, I really don't have much of a barrier left. So you guys have heard of NSAID-induced ulcers, correct? This is how. This is what's causing it. But wait a second, didn't we talk about stress? And if I have stress, I'll release epinephrine and norepinephrine. If I release those two, what happens to the microvilli? Remember that ultimately I said that you have arteries and arterioles going up into these? And then I have an AV anastomosis between the bottoms of these. And who opens those? Norepinephrine. If I open those, will I lose the microvilli? Yes. Will I lose the mucus that covers it? Obviously, yes, and the glycocalyx on top of that. So when we talk about stress-induced ulcers, do you see how they're losing the barrier? It's not too much acid, it's loss of barrier is causing the problem. Let's go back to the slide now. So stress from burns has to be second, third degree burns. They're hospitalized. They're stressed out. Are they losing their microvilli? Yes or no? Are they losing their mucus? Are they losing their glycocalyx? They're losing everything. So all of a sudden we slap a name on it, call it Curling's ulcers. How do I remember that? If you take a flame and you burn a piece of paper, doesn't it roll up? It curls. That's how I just remember that. All right? So Curling's ulcers is from burns. Increased intracranial pressure. Increased intracranial pressure. Do you think that's stressful? Absolutely. Stressful to the body. Body's trying to fix something it cannot. Very, very stressful. And probably was a stressful situation leading to the increased intracranial pressure to begin with. Maybe he got whacked in the head with a baseball bat. Maybe he fell or had a motor vehicle accident. Stressful situation. Either way, they're going to lose their microvilli, and ultimately we call that Cushing's ulcers, folks. Seizures. They foam from the mouth, they defecate, they urinate. Isn't that all parasympathetics? So if somebody has a seizure right in the beginning and right in front of you, you see them foaming from the mouth. If it's a generalized tonic-clonic seizure, they defecate, and sometimes they go ahead and they void at the same time. That's all parasympathetics first. That's not sympathetics. So every book that tells you sympathetics is first is wrong. I can prove it based off of physio. All right, so they're skipping that first part. All right, good. All right, so we go into something we call the oral phase. The oral phase. So based off the oral phase, put food in your mouth, salivary glands respond. No surprise there. So what I did is I put a little list there. Salivary glands, a parotid in front of the ear has serous under cranial nerve 9. The rest are under cranial nerve 7. So which one do you think they're going to ask you about? 9. It's the outlier, right? That's the one they're going to ask you about. Lingual, on the tongue, most serous also. So I have 2 very watery and 2 that are very mucinous. Your sublingual and submandibular. See, saliva in your mouth has to be hypotonic. Why? If I take food and I put it on my mouth, how do I break it down? Is I want water, being in a hypotonic situation, to infiltrate that food. If I had hypertonic solution, osmolarity would be very high and water would not soften that food. Therefore, it would be very hard to eat and digest food. So saliva has to be hypotonic. Now, food in your cheek, remember that you have very mucinous glands, your sublingual and submandibular. Food will get stuck in the side. So if you're sucking down a gummy bear or taffy, and all of a sudden you're like digging in your mouth to try and get it out, it's not necessarily adhesive properties of that candy. It's because you got a lot of mucinous glands in that area. All right, a lot of mucinous glands in that area. Now, this takes us up into a picture or diagram that I made for you because a lot of students were having a hard time with this. I'm going to add one thing to this picture just for completion. I'm going to put a blood vessel following the outline here. So if I would put a blood vessel running along the top here, all the way down and around the side. All right, that's your blood vessel. Now, you know every sodium, potassium, ATPase is 3:2. In the picture there, I have isotonic plasma, primary saliva, comes right across into the gland. And this would obviously be coming out of the gland at the bottom here. Now, water, obviously, we have sodium, which come across. Everything's isotonic. Isotonic. One thing I want you to know about this diagram is that if you look, it's impermeable to water. Impermeable to water. So the water that leaves the blood and enters the gland will eventually leave the opening of the duct. All right? It does not penetrate the walls. Now, isotonic originally, I take 3 sodium and I exchange it for 2 potassium. Just that alone. Do you see how I'm at a deficit of 1 sodium? Or I should say 1 electrolyte. Do you see that so far? 1 electrolyte, I'm at a deficit right at that point. Well, I have chloride and bicarb that exchange 1 for 1. So since I've lost 1 sodium here, or 1 electrolyte totally, at the end, the bottom line is my saliva is hypotonic. Everybody understand that? Hypotonic because I've lost 1 electrolyte. Now there's 2 possibilities where I can have isotonic saliva, possibly even hypertonic saliva. Sympathetics as well as parasympathetics. Let's discuss that. Go over the diagram one more time? Sure. So isotonic, obviously our plasma is isotonic, correct? Or should be, providing I have no pathologies. So isotonic plasma will come across here. As it comes across, remember that water is impermeable. So it'll come right on out the duct. As it's coming across, I'm going to take 3 sodiums out of this isotonic solution and pull it off and put it back into blood. So it's basically doing an angle here. You got it? But I'm going to take 2 potassium from the blood and replace it. I'm doing it against a gradient. That's why I need ATP. By doing that, do you see how I have a deficit of 1 electrolyte? 1 electrolyte is a deficit already, so then I'm already hypotonic at that point. Do you agree? I have an exchange of chloride to bicarb, which is 1 to 1. So ultimately, my net effect is what? Hypotonic fluid. Sure. So hypotonic fluid is my net effect. Now, there are situations where I can either speed it up or slow it down. Speed it up or slow it down. If I have parasympathetic effect, because isn't that first in all stress responses? Parasympathetic moves blood faster past the gland. So let me give you an example. Let's say you're taking that little white bus here to the program, and that driver decides to not slow down here and keeps it at maybe 15 miles an hour through this little alleyway here. You have time to get off the bus? No. So if I have blood moving really fast past this area, do I have time to make the exchange? No. So if I do not have time to make that exchange, will I have more sodium in my saliva? Is that why when you exercise, all of a sudden salt builds up in the corner of your mouth? Ooh, imagine that. Is that why when you're starting to sweat, you have more salt on the skin? And you start to itch more? Because it's irritative to the skin? But wait a second. If that is soon followed by parasympathetics, soon followed by sympathetics, doesn't that cause vasoconstriction? If I have vasoconstriction, will I pull this blood vessel away from the gland? Yes. If I pull that blood vessel away from the gland, can I exchange? No. That also explains why, through the parasympathetic into the sympathetic phase, why that salt remains on your system, because it is now an isotonic solution. It's not a hypotonic solution. Everybody understand? Yes? Moving too fast. Parasympathetics? Muscarinic. Remember, parasympathetics are under muscarinic control. You have blood always moves faster in a parasympathetic state versus sympathetic. I'm constricting.
I thought you had the parasympathetic. I'm just confused. I was thinking you have increased flow but decreased velocity.
Don't get into velocity. You have increased flow. You just answered the question. If I have increased flow, do I have time to exchange? No, and that's where I'm going here. Okay. All right. Everybody okay? All right, good. So parasympathetics, acetylcholine. What's unique about acetylcholine? Remember that it stimulates the CNS and the PNS, peripheral nervous system. So it's excitatory to the brain, and it activates all muscles, all skeletal muscles especially. Remember, it opens your sodium ligated channels. and you get muscle contraction. Methylcholine is the old drug we used to use to diagnose asthma. Now we have spirometry, so we don't have to do this. We stopped doing this because of those unsuccessful people. Lawyers. Right, beta-2 agonists to bring the patient out, so you had to always have that on board. Pilocarpine. Pilocarpine is for cystic fibrosis, right? Let me explain how this drug works. If you suspect, based off of history and everything, that this child has cystic fibrosis, we do what's called a sweat chloride test. Well, in the olden days, midwives used to lick the forehead of the children, right? And taste it. If it was salty, they'd say, oh, this kid has cystic fibrosis. Obviously, they had other pulmonary congestion and things like that. Well, nowadays, what they do is they take an electrode, and they take a pad, and they put pilocarpine on it, and they put it on the skin. And they take another electrode just to ground it on another part, and they put electrical impulse to it. The pilocarpine goes into the skin. When the pilocarpine goes in the skin, then they take that electrode away, and they put a piece of a certain special kind of paper on top of it and let it sit there for 30 minutes. They take that paper off, and then they weigh it. And they have a way of testing the chloride and the sodium within that paper. And that's what a pilocarpine sweat test is. And that's for cystic fibrosis. If I have a sweat test greater than 60 milliequivalents per liter, then I know that ultimately it's diagnostic. Open angle as well as acute, it's acute open angle and closed angle glaucoma. Just glaucoma in general, we use this. Why? Because it stimulates basically the iris to contract, and it'll open the trabecula of the eye so that I can have increased flow. Carbachol and bethenacol are used for post-op urinary retention. So if I need to stimulate that bladder, muscarinics, remember the detrusor muscle, then ultimately I can help them void. This is assuming that there's no problems where they had prior normal kidney function as well as bladder function. All right, sympathetics, norepinephrine. Let's see what else. Alpha and beta-1, epinephrine, has a methyl group. That's a board question, folks. That is a board question. I think it's crazy, but they ask you, what's the difference between norepinephrine and epinephrine? Epinephrine has a methyl group. Kind of crazy. Doesn't test you clinically on absolutely nothing, but that's a board question. Ephedrine, over the counter, remember it's a stimulant basically. Pseudoephedrine with stress incontinence. Pseudoephedrine with stress incontinence. Al, do you know how many incontinences we have? Yep. How many? 4. Oh, okay. Teach me an extra one. Urge. Okay. So gotta go. Good. There's stress. Okay.
There's overflow.
And overflow. Those are the 3.
And then there's the one where you can't make it in time because you broke your leg or whatever, and so you're hopping.
Okay. You said you break your leg and you can't make it in time to the bathroom, so that's incontinence. Okay, that's pretty good. So, stress, urge, and overflow, folks. Those are the 3 I want you to know. Now, we'll talk more about this in renal, but I want to give you stress incontinence right now because this is a drug associated with it. I have a piriformis. She has her bladder up here. And I have a muscle that retains that. This is called the urogenital diaphragm. Remember, that's one of the muscles, urogenital diaphragm. That's one of the muscles of the floor of the pelvis called the levator ani. Now, what happens in stress incontinence? Al, do you know the most common cause of stress incontinence?
Sneezing.
Okay. So every time somebody sneezes, they're going to have stress incontinence?
It's like lifting or...
You haven't had a date in a while, have you?
No.
So go ahead. Anybody? What's the most common cause of stress incontinence? Come on, you can't be wrong. Cough. Well, that induces it, but what's the cause of stress incontinence? Childbearing. Right. Lots of children or difficult vaginal delivery. So therefore, I wouldn't expect to see stress incontinence in a woman that has ultimately vaginal C-section. So think about this for a second. You guys remember Starling's forces, right? I take a muscle, I stretch it, and as I'm stretching it and I get beyond a certain point, Starling's forces means the contraction will be stronger, correct? But if I take Starling's forces and I stretch and stretch and stretch, I can destroy that muscle, couldn't I? And I fray those fibers. Absolutely, and that's what happens with a difficult vaginal delivery. They destroy some of those muscle fibers. Can you ever regain those muscle fibers again? No. No. Once you destroy them, that's it. Now, that's why we turn around and we say multiple vaginal deliveries, because you destroy different ones along the way. Somebody else give me another connection too? What else is responsible? Estrogen. 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 Think about this. Let me think here. But you may say, wait a second. What type of patient do we see this in? Stress incontinence. Obese women. Obese women, usually in their 40s and things like that, right? Obese women, stress incontinence. So estrogen. Estrogen, as well as multiple vaginal deliveries. Multiple vaginal deliveries, or difficult vaginal delivery. So based off of that, Starling's forces, I'm going to turn around and destroy those muscles. Let me ask you this. What's the treatment of choice for stress incontinence? Surgery. Oh, we have a surgeon in the midst. Get him in my OR. Kegel. Right. Kegel, right? What is Kegel? It's what?
It's a workout.
What's this?
It's a workout.
Ow, you need a date. So,
Exercise the pelvic floor.
right. So what do? I give them a bunch of weights, have them get in their sweatpants. Bear down. Grab and squeeze. Put on a squeeze, grab. Okay, got a lot of problems. So they put on a World's Gym shirt, you know, and put the bandana on the head, the leggings, right? You know, whatever it takes, right? No. The key is I either have a physical therapist trained in women's health or a nurse practitioner, again, trained in women's health, who basically there are these vaginal weights that she uses. And she practices doing different abdominal exercises to help strengthen that muscle. But let me ask you this. Is that going to work? Does it work? No? Yes? What was the problem again that caused it? Overstretching the muscle and estrogen. So if you turn around, most of these individuals are already non-compliant with an exercise regimen, and you say, Mrs. Johnson, here's a bunch of weights for you to swing around the house when you're exercising. Is she going to use them to begin with? No. But if she does, are they going to work? No. In order to be eligible for, it's called urethroplexy, which is the surgery where we pull that up and tie it off, you have to have 3 months of failure of Kegel, deemed by the insurance companies. Now think about that. They're already doomed to fail, aren't they? So what should be your first step in management with stress incontinence? What is it? What was the problem again?
Lower the estrogen.
Well, it's a little hard to do that. Well, how are you going to lower the estrogen? Exercise and diet, right? Because ultimately if she loses that fat, which contains estrogen, she's going to lower that estrogen content, and therefore if I give her Kegel exercises after that, more likely to work. And who did I tell you is the one type of individual you do not want to do surgery on? Obese. But you're wanting to run to the OR with her because I want to go ahead and do procedures. See the danger to that? So adds to the comorbid conditions. So be careful with that. So stress incontinence, and what actually happens with that is this urogenital diaphragm retracts. And if I'm normally, when you increase intra-abdominal pressure, it pushes down on the head and comes down here and works on the sphincter that's down here. Now, with stress incontinence, that bladder falls. So therefore, if I'm increasing intra-abdominal pressure to void, you can see that ultimately they can't get down to where the sphincter is because it fell down. And that's what happens in stress incontinence. But that brings up a new point. If you said that it's due to estrogen relaxing the muscles, let's take that up to the gallbladder. The gallbladder's surrounded by muscle, isn't it? And who's the hormone that squeezes the crap out of that gallbladder? CCK, WWF, right? Yeah, squeezes that gallbladder. Huh. Who gets cholecystectomies? Fat, fertile, female, 40-ish? Huh, imagine that. You mean that they have a lot of estrogen floating around? If they have a lot of estrogen floating around, does it matter how much CCK is there? If I have all that CCK to do the WWF slam down on that, is it going to? It's not going to work because that muscle's relaxed due to estrogen. And you wonder why it's always obese women, or majority of them, that are getting cholecystectomies. It's all physio, folks. All physio. All right. Moving on. So let's see, pseudoephedrine for stress incontinence, because ultimately I can help buy some time while she's exercising to tighten that sphincter. Remember, think about it. I told you the individual's usually obese, probably not in an exercise regimen along with diet, and you're going to tell her to go to the gym and start exercising? Problem is she doesn't want to. Why? Because if she gets in that gym and starts exercising, won't that be stressful? If it's stressful, won't she void? These women could live normal lives, but they don't, because every time they go out into public, they're afraid to go to the movie theaters and things like that, because every time they laugh, cough, sneeze, they void, and it's humiliating. So something that's very easy to take care of and fix, to put this person back and have a normal life, they become prisoners of their own house. And that's the sad part about this. But it's something that's very easy, very common as women age. Okay, very common. And we can give them pseudoephedrine ultimately to help constrict that sphincter so that she could go to the gym. All right, so results. I have phenylephrine here too, neurogenic shock, so it helps constrict the vessels ultimately, because remember, in neurogenic shock, they have vasodilatory problems. So result, removes blood supply to the GI, causing a decrease in saliva that has increased osmolarity. Remember I told you we go from a hypotonic back to an isotonic because we keep that extra sodium in there. And that's why with exercise you get that dry mouth, the film in the corners. Everybody okay with this? This is a concept that's tested on a lot. Everybody okay? All right. All right, and we'll just finish up with cystic fibrosis, and then we'll stop there. Now, cystic fibrosis, most common cause of malabsorption in children. Most common cause of malabsorption in children. Are they going to have steatorrhea? They could, sure. Well, you know that CFTR gene on chromosome 7, that's what everybody memorizes, right? And you're hoping that they're going to ask you about that? Are they going to? Nah, because they know you know that. Everybody knows that. Defective chloride transport, we kind of know that. That's why we do a sweat chloride test. Simple enough. Chloride traps sodium, increasing the salt content and thickness of secretions, affects the GI, the lungs, the parenchyma, the sweat ducts or sweat glands, and the epididymis. Now, I'm going to show you how they're going to try and trick you on the boards on this, because the way you look at it, they're going to ask you just the opposite. All right, let me show you what they're going to do. So based off of a duct, if here's a duct, and I have a cell over here, and I have sodium and chloride out in the duct, I have a transmembrane transporter, basically, where I'm supposed to get sodium and chloride into the cell. Well, with cystic fibrosis, that's what's screwed up. No surprise, right? Because then what happens is when we do that pilocarpine test or whatever, sodium as well as chloride come out into the sweat. Everybody knows that already, right? That's simple enough. Sodium and chloride cannot get into the cell. But that's not what they're going to ask you about. Because they know that you know that. Everybody knows that about cystic fibrosis. They're going to take it to the lungs, the epididymis, the pancreas. Because what actually happens in those areas? Do I have sodium and chloride high in my secretions? Oral secretions? Pancreatic secretions? Yes or no? You think yes, but it's no. Let me explain why. Let's say I take the lungs. If I'm looking at the lungs, and I put a cell out here, I have my transmembrane, sodium and chloride can get into the cell, but the problem is that they cannot get out. They cannot get out of the cell. Cannot get out of the cell. If I have sodium, who loves to follow sodium? Water. Water. Now look what happens here. Where I have cells in the pulmonary system here, I also have in between these cells, cells called goblet cells. And what does a goblet cell secrete? Mucus, right. So it's going to secrete all this mucus. Now that mucus is kind of pliable, right? It kind of moves. It has disulfide bonds. It has water in it. It can kind of move around. And as we cough, remember that mucus moves 1 inch every time we cough. Now think about that. If I have all that mucus there, and I said, who was caught inside the cell again? Sodium and chloride. And so who's going to get pulled from the mucus? Water. Water would get pulled from that mucus. So if I pull water from that mucus into the cells, won't it make that mucus even thicker? Isn't that part of the problem with cystic fibrosis? Don't they have these mucus plugs? Whether it's in the pancreas, the epididymis, whether it's in the bronchioles. Are they going to have a hard time moving air past that? They'll get goblet cell hyperplasia. And it's going to kick out more mucus and more mucus. Will it pull out more water from that mucus? Absolutely. And it's a spiraling effect. And this is what happens. Don't we turn around and with children who have cystic fibrosis, they have a respiratory therapist doing back compressions to basically help shake up or loosen that mucus? That's what's happening in cystic fibrosis. So let me ask you again. In sweat, is chloride and sodium high? In cystic fibrosis? Yes. How about pulmonary secretions? No. Pancreatic secretions? Epididymis secretions? No. Which, now you know how they're going to go after it on the test. Don't mix them up. Just the opposite is what's happening. But they know you know the first part of it, not the second part. All right, good. So with cystic fibrosis, remember meconium ileus, first presentation in neonates. Malabsorption develops as pancreatic ducts become clogged. Why? Because it's the mucinous cells, or goblet cells, kicking out the mucin that's creating an obstruction of that duct. Could they get a pancreatitis? Absolutely. Remember that pancreatic enzymes are let's see, how can I say this? Pancreatic enzymes are secreted in their inactive form called zymogens. And if they hang around long enough, they're going to become activated. If they become activated, they'll start chewing up the tissue in that area. So they can get a pancreatitis, sure. Let me ask you this. Infertility in men develops as the epididymis is clogged. They're unable to ejaculate. But are they infertile? No, it just can't get it out. Obviously, if a prolonged period of time, it can destroy the tissue in that area. But again, they have a blockage. And obstructive lung disease develops over the years, unable to cough up that thick mucus. Unable to cough up that thick mucus. Yes? Meconium ileus is where basically, remember that I have mucus cells and all that also within the GI tract. Meconium ileus, they're not moving anything. An ileus means lack of movement. So remember that I have sodium-potassium channels also within the ascending portion of the GI system. And remember, they're pulling water out of that stool, so everything's sitting still, and therefore I get no movement. That's meconium ileus. All right, meconium's first stool. Yes? Anything else? No? Absolutely. But if I have it in a newborn, I'm going right away to start ruling out cystic fibrosis. Well, remember, Hirschsprung's is basically a problem where I lack my R-box and my enteric plexus, and they're going to get an enlarged sigmoid colon because it's going to be backed up, and I'll have that constriction there. Different presentations, huh? Sure, because you're not moving it, but there's different presentations off of that. Remember that if I have meconium ileus, it doesn't necessarily mean I'm going to have a large bowel. But if I turn around and I have Hirschsprung's disease, then therefore they can have a large bowel from it stretching everything. Because they're still having that movement, it just can't get out past that anal sphincter that's in a constricted state. All right, now, worst bacteria enemies, Staph aureus and Pseudomonas. Folks, if you ever think the answer is Staph aureus on the boards and it's not there and Pseudomonas is, I want you to always pick Pseudomonas because they go hand in hand. Must cover Staph with 1 antibiotic and Pseudomonas with 2 antibiotics. When we do micro, I'll break that down a little further. We have that pilocarpine, which we talked about, how to do that. It's a chloride sweat test. I have some different numbers up here from your notes. I want you to change it. Normal is less than 40. Make sure this is the updated numbers. Normal is less than 40. Heterozygous, which means that you're kind of right at the level, is between 40 or 60. And if you exceed 60, then ultimately you have cystic fibrosis. That's for chloride. For sodium, sodium should be less than